Good afternoon to everybody east of Thunder Bay, and good morning to the west. Welcome to the very first day of Canadian Patient Safety Week, the annual campaign that started in 2005 to inspire extraordinary improvement in patient safety and quality. We'll just advance the slide one to bring up our introductory. The Canadian Patient Safety Institute presents vital patient safety information to anyone who engages with our healthcare system, providers, patients, leaders, and citizens. Working together, we can all help reduce the impact of this silent epidemic that claims 28,000 lives every year. My name is Christopher Thrall. I am the Communications Officer with CPSI. I would like to welcome you on behalf of our technical host, Barb Lafour from CPSI, and also on behalf of our sponsors for Canadian Patient Safety Week, Gojo Industries, and HealthPro. We'll be hearing from a series of outstanding speakers today who will each address the silence that impacts our healthcare systems. If you miss part of this webinar or want to share your learnings with others in your team or organization, please know that it is being recorded and will be available on our website within the next week. There will also be a quick survey at the end of the webinar. Please put your questions in the Q&A box on your screen or chat them directly to me, Christopher Thrall. They will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, please connect with us in the chat box and we would be happy to assist. I keep mentioning silence. This is because we are facing a silent epidemic, one that most Canadians don't even know exists. At some point, every one of us will be a patient in the healthcare system. 1 in 3 Canadians has suffered from preventable healthcare harm, and yet we still don't talk about it. If we do nothing, 1.2 million Canadians will die from preventable patient harm in the next 30 years. During this year's Canadian Patient Safety Week, we are launching a new theme. We ask you to help us conquer silence. This silence exists between patients and providers, between colleagues in healthcare facilities, between administrators in different regions, and between the public and policymakers. We want to teach people in Canada that if something looks wrong, if it feels wrong, or if it is wrong, we need to speak up in the moment. Here are 3 things that each one of us can do right now to help spread awareness about the 3rd leading cause of death in Canada, preventable healthcare harm. 1. Your voice has the power to save lives. Donate your voice today by recording your healthcare harm story and share your advice to help others learn from your experience at conquersilence.ca. 2. Listen to the new episode of our award-winning patient podcast to learn how to conquer silence and what we can do to stay safe. Download it at patientsafetyweek.ca. 3. Participate on social media using #ConquerSilence and speak up for patient safety. Together, we can save lives. Now let's invite our speakers to tell us how they have succeeded in conquering silence. Lisa DeAngelis is a registered nurse and clinical advisor for HealthPro's anesthesia, respiration, PI, and IR team. For 6 years, she has worked in healthcare settings ranging from trauma and emergency medicine to community hospitals. Lisa, thank you so much for joining us today.
Thank you very much, Christopher, and good afternoon to everyone, or good morning to these that are joining from us from out west. As mentioned before, my name is Lisa DeAngelis, and on behalf of HealthPro, we are honored to sponsor Canadian Patient Safety Week and speak with you today. As mentioned, I am a registered nurse and have worked as a frontline clinician in a variety of healthcare settings, ranging from trauma and emergency medicine at a major trauma center to working at a community hospital. Today, I continue to practice in hospital on a casual basis, in addition to working for HealthPro as a clinical advisor. Many of you on the line are probably members of HealthPro and may not know it. We are owned by 1,300 healthcare facilities across the country, and we aggregate purchasing volume so that you can get the best price on high quality products. In my role as a clinical advisor, I help set criteria for the products and then help to evaluate them to ensure that they meet the highest safety standards. As you know, though, having safe products is only part of the equation when we're talking about patient safety. As mentioned before by Christopher and as reported by the Canadian Patient Safety Institute, 1.2 million Canadians will die from preventable harm in the next 30 years if we don't change this silence epidemic. If something looks wrong or feels wrong, we need to speak up. The notion that we can't really be afraid to speak up, even if it's uncomfortable, is so important because it does save lives. In my own experience, speaking up has been instrumental in patient safety. I work currently in a trauma and emergency center. Things can get pretty chaotic in the department and situations easily arise. At many times, you're tasked with caring for multiple patients with high acuity. It's always important to remember to verify your work before you act. I would like to share with you a quick experience and situation that happened in my career. I was working a shift caring for multiple patients with high acuity, one of them being a patient of the intensive care unit. This patient was hyponatremic. Now, for the clinicians out there, we know that hyponatremic means they have a low blood sodium level. In order to correct this, we increase that sodium level, but at a slow rate. If we do it too quickly, we can cause something called cerebral edema, and that is the swelling of the brain. Now, when reviewing the orders for this patient, I noted that the rate at which they had recommended increasing that sodium level was quite quick. Knowing that things can change and always wanting to follow best practice guidelines, before carrying out this order, I called to clarify this order with the physician. Had this order been carried out or taken through, it could have been detrimental for that patient's safety. In calling to clarify those orders, it was escalated to speak with the staff physician in the intensive care unit, and it was noted that that rate was too quick. So because of that recognition, we were able to change that order and ultimately help that patient stay safe, healthy, and that patient is alive and well. So in conclusion, I'd like to remind everyone that it may be uncomfortable to speak with those physicians. It may be uncomfortable to ask the questions, but we always need to make sure to ask those questions to help those patients. Thank you so much for listening to my quick little story, and I'll turn it back over to Christopher.
Wow, thank you so much, Lisa. An excellent example of speaking up, and thank you for your comments. Please stay with us, and we'll take the questions that came in at the end of the webinar. Our next speaker, thank you. Our next speaker, Bernie Weinstein, was born and raised in Montreal. He spent 33 years with CN Rail, first as an engineer and then retiring as director in Corporate Economics and Strategic Planning Office. He is now actively involved as a patient advocate at the Jewish General Hospital and as a member of Patients for Patient Safety Canada. Bernie, thank you so much for joining us here today.
Thank you, Chris. I'd like to tell you a little story, first of all. The story is about my mother-in-law, Claire Friedman, who was a patient in the Jewish General Hospital. She was 83 years old and was in the geriatric center, having survived stomach cancer surgery and waiting to be admitted into a senior's resident. She was a very active person, spending most of her time walking around the ward, talking to the other patients and the staff. Before Mother's Day, 2002, we arranged with the nurse to take her to her daughter's house on Sunday for the afternoon so she could spend the day with her family. We were all very excited. This was going to be her first trip away from the hospital since being admitted in January. As was our habit, we showed up on Saturday at noon to help her eat lunch and to spend some quality time with her. When we came in, we found her tied to a chair in front of the nurse's station. She was non-responsive. When we asked the staff what had happened, we were told everything was okay. This is normal. This is what happens to women at her age. When we challenged them, we were again told, don't worry, this is normal. We were told we could probably take her out on Sunday. On Sunday, we came back, and she was better, although not up to her old self. The doctor told us it was okay to take her out. When we confronted him, he told us that the nurse had given her the wrong medication and that it would eventually pass through her system. We were told, don't worry, she's okay. I told the doctor and the nurses, plus the social worker, that I was going to make a formal complaint to the hospital's ombudsman, which I did the next day. Shortly thereafter, I got a phone call from the Director of Professional Services, who fully explained what had happened and what the hospital was doing. He also asked me if I would be interested in joining the Risk Management Committee as a patient family representative. I agreed to do so. I'm still there. I now also volunteer in the quality department. Few weeks later, the doctor, social worker, and nurse had a meeting with my wife, my sister-in-law, and myself, and explained what happened. I should point out, they didn't apologize, either for the medication error or for lying to us. Since then, many things have happened. Could we show the first slide? This is a picture of the disclosure pamphlet that I was asked to work on. In fact, you'll see the back of my relatively bald head and my wife's head on the picture. This is the pamphlet that was produced so that we could train all of the clinicians in the hospital how to go about the process of disclosure. This is a policy that was approved by the board of directors. Took us about a year until we finally implemented it to all of the doctors, nurses, other professionals, all of the clinicians in the hospital. And this became the cornerstone of the hospital's policy, which they called no name, no blame, no shame. As a member of the Quality and Risk Management Committee, I was also asked to chair a committee to develop a Speak Up policy, procedure, and program for the hospital a couple of years later. Can we see the next slide? This is a copy of the Speak Up brochure. I'm not going to go through the whole Speak Up campaign, but suffice it that the headline is, if you don't understand something that any member of your healthcare team has told you, the hospital has resources available to help you. Identify yourself clearly to your healthcare team. I've taught this Speak Up program throughout the Jewish General Hospital and now the wider health network that it's part of, in many hospitals and private facilities in Montreal, to many service organizations in Montreal, virtually across Canada as part of the CPSI team. I've even taught this in the United States. This policy, procedure, and the pamphlets, as well as the video that we produced, have been used in hospitals in the United States and as far away as Saudi Arabia, where the largest hospital adopted this policy and procedure as their own. Speak Up is a way not only for patients, but also for clinicians to learn how to speak to each other so as to avoid error or to identify errors that have occurred and to try to correct them. I encourage you all to look into this and to speak up whenever you can. Thank you very much.
Wow, thank you so much, Bernie. That is exactly the message that we're getting out today, is to speak up, is to conquer silence together. In every Canadian Patient Safety Institute project, we make sure to invite a patient member to remind us of why we do the work we do. Bernie's story, both in the harm that they suffered and in the silence that he conquered, is why we're here today. Please note that you can submit your questions in the chat box to me, Christopher Thrall, or in the Q&A box on the right-hand side of your screen. Our next speaker is Sandra Hanna, Interim CEO of the Neighborhood Pharmacy Association of Canada. She is also a practicing pharmacist with experience in community, hospital, long-term care, and specialty pharmacy settings. Welcome, Sandra, to the webinar today.
Thank you, Christopher, and thanks everybody for joining this morning, or this afternoon, I guess, depending on where you are. And thank you so much for having me as one of the presenters. So, as Christopher mentioned, I am a pharmacist, so I bring, in this presentation, the perspective of my clinical practice, but also what I'm seeing from an advocacy standpoint and the work that we do at Neighbourhood Pharmacy Association of Canada, which advocates on behalf of our members that deliver care in communities. So just to give a little bit of background in terms of pharmacy in Canada, there are now probably just over 10,500 pharmacies in Canada, which means that there are effectively pharmacies in virtually every community across the country, which also means then that pharmacies become the most accessible point of care for patients. Not only are they conveniently located in just about every community, but also they are typically open longer hours, they're open on weekends, and they're very easily accessible without appointment. In addition to that, there have been a number of studies and surveys that have shown that pharmacists are very well trusted among the healthcare system. When we look at the majority of healthcare providers, the amazing thing is that patients still feel a significant and great amount of trust for their healthcare providers, whether pharmacists, nurses, physicians, paramedics. And I think this is really important to recognize that despite the fact that we are seeing a lot of, new sort of, divergence from traditional models of care, and we're really diverging and moving away from a paternalistic model of care, which is great, and engaging patients more, which is fantastic, but there still is a significant amount of trust that is placed in healthcare providers, which positions us really well to help welcome and open that dialogue with patients. So the one additional piece that I would add to that is that there is a significant amount of loyalty and access and accessibility with pharmacists that I think is an untapped resource, both from a pharmacy standpoint, a patient standpoint, and a health system standpoint altogether, when we think about how we work together as healthcare providers. Patients typically will return to the same pharmacy the same way they will return to their general practitioner or their family physician, primary care physician. So there is a relationship that develops, and patients will typically see their pharmacist up to 10 times more frequently than they'll see any other healthcare provider. So this presents a great opportunity for us as providers to work together and leverage the information and the relationships and the trust that is built between patients and every single one of us when we look at the circle of care. So when we looked at, we did a survey last year among healthcare providers, and typically, as I mentioned, there is an amount of trust, in all healthcare providers, but additionally, there is an additional amount of accessibility and convenience that is seen among pharmacists. And this is the area where we can really leverage the accessibility of pharmacists and how frequently they're seeing the patients. Especially in an area where we're seeing a lot of disruption in the way people are seeking care. And there's disruption in so many areas. So, how are patients finding health information and seeking care? As you can see here, about 1 in 20 searches on Google are health related. How are patients receiving care? Amazon is getting into distribution of healthcare. We're seeing a surgence of, an increase in the amount of virtual care that's happening. How are patients monitoring their care through wearables and applications? And even the type of care, that patients are seeking. We've seen a major shift in, the focus on wellness and alternative medicines, and we're seeing the growth in the use of things like cannabis. So what does this mean to us? Are we fighting one another? Are we trying to work against these disruptors, or rather are we working together, to think about how we can leverage some of these things and how we can work with some of these things rather than against them, to understand what therapies are most relevant and appropriate for patients, and how and when these options work together and how and when they don't. So I think what we really need to focus on is that patients are an ultimate decision maker in their care, and how do we meet them where they are and understand where they're coming from to together best support them in that journey. And I think from that perspective, we as healthcare providers can only advise and inform and help patients make the best decisions for themselves. And when patients receive consistent information from various sources, from various healthcare providers, in addition to the various other sources they're seeking for their healthcare, those decisions become much easier and much clearer. However, when information is conflicting and those links are not drawn, then those conversations and those decisions become much more difficult. So I think the more information that we can gather from patients, the more effective we can be at advising them. But if the information we gather, it often relies on information sought from patients. And the success and effectiveness of our care plans really hinges on patients' engagement, commitment, and buy-in. Whether it comes to medication adherence, whether it comes to monitoring, diet and nutrition, exercise, meditation and mindfulness, all of those require patient buy-in and engagement to actually see any benefits. So how do we do that? And how do we work, again, with one another and with these quote-unquote disruptors to meet patients where they are, understand what they're seeking, and work with that rather than alienating them and driving them to those either-or decisions. So I include this because I think that it nicely illustrates where patients are seeking care. So it could be from traditional means of physicians or their pharmacists, allied health, but then there's also family and caregivers. There's hospital, there's Google, there's friends, there's home care. So understanding and having that dialogue with patients to understand what are their motivations and what is the belief system that influences their healthcare decisions. What are their preconceived notions about their health, things that they've tried, things that they haven't tried, things that they'd like to try or don't want to try. Understanding where a patient is coming from and what influences their decisions is critical for us to understand the type of information that we need to provide them to best inform them and best empower them to make those decisions. Understanding where patients seek care and where they're actually looking for that information is critical for us to be able to leverage those resources where possible. If a patient is really health literate and really doing a lot of research, it's important to bring that into the discussion so that you can speak to them at that level and understand the information they're gathering and help them to sift through that information and make it relevant to them. If we know that a patient is seeking potentially care from a different means or a different provider that perhaps doesn't align with our typical views, it's critical for us to understand and put aside any intentional or unintentional commentary around our beliefs in terms of what type of care they're seeking. It's critical for us to create that safe space that enables and welcomes full open dialogue with our patients so that we have the information that we need to best understand how patients are going to take the information we provide to them and how they're going to put it into their own care. Consistency, convenience, and frictionless experiences are being sought by consumers of all goods and services today. Health is no different. We have to be consistent, we have to make it convenient for patients, and we have to help them to interpret the information that they're receiving from all different areas of the healthcare system or of what's now being expanded into this healthcare system and healthcare resources, I guess, that patients are seeking. So most importantly, I think, is opening up that dialogue and really asking questions and ensuring that we as healthcare providers not only understand from patients, but also understand from one another how we can leverage one another's abilities to make the experience as convenient and as frictionless as possible for the patient. Thank you very much.
Oh, thank you so much for your perspective there, Sandra. Her bio actually mentions that she is passionate about advancing pharmacy practice and finding novel ways to deliver enhanced patient care. And today, she helped us confront and conquer silence. Thank you, Sandra. We delve further into conquering silence with Dr. Ward Flemons, our next speaker. He's medical advisor to the Health Quality Council of Alberta and former vice president of Quality, Safety, and Health Information for the Calgary Health Region. He practices as a respirologist and sleep medicine specialist at the Foothills Medical Center and is professor of medicine at the University of Calgary. He works with patients and families who have experienced serious patient harm, and he lectures nationally on patient safety and quality improvement. Thank you so much for joining us today, Ward.
Thanks, Chris. So good morning, good afternoon, everybody. Chris and Barb asked me to speak a little bit about what we're doing in the University of Calgary to create a curriculum in teamwork. We've done this for undergraduate medical students, but it's applicable to pretty much anybody who wants to learn teamwork, including patients. And I'll just take you through what we've been working on a little bit here. So I put up this slide just to remind ourselves that the origins of teamwork and the rationale for teamwork comes from aviation. Some terrible airplane accidents in the mid-1970s highlighted the need for this by the fact that very experienced pilots working in planes that were completely intact with no problems still ran into terrible problems due to breakdowns in the way that people interacted with one another. And Bob Helmerich, who's pictured there in the bottom right, was the human factors expert at the University of Texas, who was one of the major players in developing the concept of crew resource management and teaching this to airlines. And it's become an industry standard now, and it helps airline crews relate to one another in a predictable way. And I think everybody, if you weren't around like I was when this book was published by the Institute of Medicine, will at least have heard about it. This was the book that put patient safety on the map, certainly in the United States, and from there in most other countries in the world. To err is human. One of their recommendations was for the healthcare system to establish interdisciplinary team training programs, and that mandate was given to the Agency for Healthcare Research and Quality in the States, and they came up with a plan called Team Steps. And Team Steps is a very effective way of getting the information from years and years of research of what makes effective teams. But it was designed as an organizational strategy, so it was designed for healthcare organizations. And the whole training is around how you get people engaged, which is great, but at an undergraduate level, before people are formally part of healthcare organizations, the training program is not completely appropriate for there. The other thing with Team Steps is the skills are interwoven into their teaching, and they're not extremely well defined. And when we're teaching in the undergraduate curriculum, we really want to be able to teach team skills that we can then test for and assess for and see whether students have actually learned them. It tends to be rather physician-oriented, and that we heard that was an issue. And the other challenge with Team Steps is just their learning approach, which is very I would say is quite passive, mostly slide decks. I think it's getting better with some more active learning, but we thought we needed to get more active learning for the undergraduates that we deal with. And the other challenge is that undergraduates really have limited or no clinical experience, so it's hard to draw on that when you're trying to teach them some skills which are often thought of as soft skills, but as those airline crashes showed, they're not very soft. If you don't do them well, terrible things can happen. Often, at least in our environment, team skills were assumed to have been learned during simulation training, sort of as an aside, but we thought that there was a need for more formal, purposeful training on team skills before people were introduced to simulation, so that they wouldn't have to learn it at the same time and really get into what we'd call cognitive overload, which is trying to teach them both clinical skills and team skills at the same time. So that led us to look at what had been published by the Agency for Healthcare Research and Quality, which has since been adopted by CPSI. So CPSI has taken it and adapted that for Canada, which is great. And then we went one step further and decided that we would take what Team Steps had done and largely follow that, but also look at the Canadian Interprofessional Health Collaborative framework, interprofessional framework, and look at what they could offer as well. And what we decided is that we would take the major categories of team steps and just incorporate the CIHC competency framework into those. So we've listed 5 skills under each of those 4 major competencies, one being leadership, and we've added in membership. One is communication. One is how do teams actually monitor situations so they can maintain a common mental model and keep that shared amongst the team. And then collaborative decision making, which really covers, in addition to covering for one another, also how do you deal with conflict within teams, and specifically, how do you make it psychologically safe for people to speak up when there could be a safety issue or when somebody perceives that there's a safety issue. So we've taken Team Scheme and we combined this with the initiative led by the Price family. And many people may have seen this film, Falling Through the Cracks, Greg's Story, which is a 30-minute film. We've shot teaching scenes in addition to this to show people interactions between various team members, but you can also see interactions between, obviously, team members and Greg, the patient. And if you want to find out more, there's a website there about Greg's Wings, which is the organization that furthers this story and furthers using it for healthcare advocacy, including teamwork training. And the important thing about the film is that for especially undergraduate students, it puts everybody on the same page with the same experience because they watch the film first, and it gives them a common story in which to base their learning on. And it also gives them motivation to learn because we bring out some of the problems that Greg had in his journey through the healthcare system was related really to breakdowns in teamwork between healthcare professionals and Greg not really being considered a member of his team, which is still a huge issue in healthcare. Patients are people that we do things for as opposed to with. So the way we've developed this, the intervention is we develop workshops in addition to developing the film with the Price family. We developed workshops that were not based on clinical experience. And the workshops use very simple things such as building a Lego tower and then relating those skills. And a lot of the skills are people working together. So it's not just building a Lego tower. There's certain rules to this so that people have to be able to communicate. They have to be able to work as a team in order to be successful. And then we relate those experiences in the workshop back to the film and try to draw parallels between their experience of working as a team and Greg's experience in the healthcare system. The second workshop is really about using the teaching scenes that we shot in addition to the main 30-minute film and debriefing the students after they've seen these teaching scenes to look for good examples which we wrote into these scenes, but also missed opportunities where teamwork didn't work, and then ask them the question, so what if? What if teamwork had been in place and had been working? What possible outcomes might Greg have experienced differently? And then the third workshop is really for them to practice some of the skills that I think are so well done in team steps that you can find in the CPSI approach to teaching team steps. And so there's specific skills and specific tools like SBAR or practicing advocacy and assertion or the approach using CUS. And what we've devised is various scenarios where students, but you can devise these scenarios for any group that's actually learning this, whether they're in practice or still in their undergraduate training, for them to practice the actual skills so it starts to become second nature for them. So our assessment so far is early on because we've only done this in the last couple of years. The film was finished in 2017, and we're still modifying the training around it. But as I mentioned, the film puts all the learners in the same experience. And using Team Scheme, it allows us to reinforce not only skills, but also concepts. And we keep drawing the students back from their experiences to both the film, but also to the framework that we've called Team Scheme. And the reason we call it Team Scheme is at the University of Calgary, we teach our undergraduate medical students about 120 different schemes. They're, for lack of a better word, pathways or ways to think through clinical problems. And so we line teamwork up to be another issue for them to learn and relate back to a framework. So the key concepts that we're trying to train the students around are the idea of all teams, effective teams, have a shared mental model, which includes both a goal and a plan. That patients are an integral part of that team. In fact, they're probably the most important part of the team as opposed to a sideline. And they're so very equally part of that team. the key that teams adapt to changing situations, and they can only do that through communication and through understanding about situation monitoring, that they have to trust one another, and you have to promote psychological safety in the team. And there's a variety of ways of doing that. So we've applied that teamwork knowledge to this framework, and I apologize for all the T's being substituted with 3's. For some reason, when I moved from a Mac to a PC, things don't work as well. But in the actual framework, there are no 3's in there, just T's. I thought I'd finish off by saying there is more information, and if people ever wanted access to the film, you can do that through the Greg's Wings website. It's run by Greg's sister, Terry Price, and her father, Dave, is also very involved in this. The whole Price family is actually an amazing group of people trying to promote better and safer care in Canada and beyond. And so you can get more information, including some resources through their website. And that's an evolving website as well. So there'll be even more enhanced resources going forward, as well as supporting communities of practice. And with that, I will stop and pass on to the next speaker.
Wow, fantastic. Thank you so much, Ward. Yeah, we're close with the Greg Price family here as well, members of Patients for Patient Safety Canada as well. So thank you very much for mentioning the Greg's Wings project. I think everybody listening here can take a page from your book as well and apply it today to help them conquer silence in healthcare. Our final speaker today is the Canadian Patient Safety Institute's own Stephen Rutledge. He leads and manages portfolios in reporting, learning, and sharing, as well as transparency policy and practice across Canada and internationally. He helps advance the World Health Organization's Global Patient Safety Challenge of Medication Without Harm and works with the International Medication Safety Network on global improvements. Steve, welcome to the webinar today. We're just going to get you to unmute your microphone there, Steve, and join the webinar.
Can you hear me?
You bet we can. Thanks a bunch, Steve.
Great. Thank you, Chris. On December 1st, 1974, TWA Flight 514 was inbound through cloudy and turbulent skies to Dulles Airport in Washington, D.C. The flight crew misunderstood an air traffic control clearance and descended to 1,800 feet before reaching the approach segment to which that minimum altitude applied. The aircraft collided with a Virginia mountaintop, killing all aboard. A disturbing finding emerged from the ensuing National Transportation Safety Board accident investigation. 6 weeks prior to the TWA accident, a United Airlines flight crew had experienced an identical clearance misunderstanding and narrowly missed hitting the exact same Virginia mountain during a nighttime approach. The United crew discovered their close call after landing, reported the incident to their company. A cautionary notice and safety alert was issued to all United pilots flying into Dulles Airport. Tragically, at the time, there existed no method or expectation of sharing the United pilots' knowledge with the other airline company, TWA, and other airline operators for the safety of their industry. This is an example of a devastating result from interorganizational silence. Following the TWA accident, it was determined that future safety information must be shared with the entire aviation community. This tragedy was a turning point for safety culture and a commitment to transparency in the aviation industry. Does it sound familiar? Because it happens frequently in the healthcare system. For this Conquer Silence campaign, I think in terms of organizational silence and the challenge of learning from one another in this complex health system. This challenge occurs routinely in Canada and around the world. If a medication incident occurs in Halifax, they go through the proper process of investigating the incident, finding recommendations, implementing those recommendations so that harm to patients doesn't happen. 6 months later, this same incident could happen in Vancouver due to a lack of learning and that inter-organizational silence. It's not a unique challenge here in Canada, as this is something that happens in health systems around the world. With that challenge comes an opportunity. Through our consultation with health systems, health leaders, and organizations in Canada, with the World Health Organization and leaders around the globe. The opportunity is transparency in learning and sharing that learning with others so that preventable harm doesn't happen to patients. A significant priority within the international patient safety community is learning and sharing across organizations and borders and promoting this more widely and effectively. The intent and goal of interorganizational transparency is to provide cross-jurisdictional learning and encourage transparency and a culture of improvement among the global patient safety community. We live in a very well-connected world, and sharing this important safety information is something that we at CPSI realized we could promote and support. One of the tools that we have developed is called Global Patient Safety Alerts. It's a publicly available online collection of patient safety incidents and recommendations containing more than 1,900 alerts and 10,000 recommendations from 26 organizations around the world. It's searchable, similar to a search engine. It's a free tool that provides alerts, recommendations, and trends from the community to help you and your organizations prevent, respond to, and learn from patient safety incidents and risks identified elsewhere. We're currently redesigning this platform to make it even more user-friendly and effective in promoting transparency and ending the interorganizational silence that prevents sharing and learning. With that, my call to action is simple. Encourage transparency in your organization to publicly share some of the patient safety information that you believe and are convinced that others could use to prevent harm. And also make a commitment to learn from other organizations beyond your borders. You'd be very surprised at how much fantastic information is provided by organizations just like yours, just outside your borders. And also, if you want more information on our tool, please visit globalpatientsafetyalerts.com and feel free to connect with us for more information. Thanks, and back to you, Christopher.
Great. Thank you so much, Steve. I really appreciate that. And the organizational silence you're helping to conquer is really going to help learning spread around the world, not just across Canada. And thanks, of course, to Ward, to Sandra, to Bernie, and to Lisa for those wonderful presentations. We went from conquering silence between patients and providers to between different healthcare providers and administrators to silence between organizations and even nations. And now we have a few questions that we've received from the chat box. We'll start with Lisa DeAngelis. You shared a story about you speaking up. Were there any negative consequences or ramifications that you had to face after doing so?
Well, in this particular case, the prescribing physician wasn't so happy to have their authority questioned, but overall it was in remembering that the well-being of our patients comes ahead of any potential political landmines, and ultimately, and it was the understanding that if you're the person administering the medication, you are accountable. So it was knowing that if something doesn't feel right, doesn't look right, we need to speak up.
We do need to speak up, but even so, it was quite brave because organizational silence is enforced, unfortunately. So that's what we're trying to overcome here today. Bernie, we did have a question come up for you, and maybe you can just sort of give an opinion on this. Marc-André Hébert asked about the benefits of having a patient or patient family member on committees of risk management, but also are they able to understand the complexities of clinical processes and conditions if they're on those committees? Can you sort of give us a pro and con, Bernie?
We currently have approximately 60 patient advisors. We've changed the name from patient representatives. And each and every one of them is either on a clinical team or on a committee looking at various ways to improve safety. One of the very first meetings that I went to, the director of professional services, who was the co-chair of that committee, stated to the other clinicians on the committee, we have enough problems in Quebec as between English and French. Let's make sure that we all understand what each of us is saying. And I think that touchstone changed the temper of the conversation. We have worked with the committee chairman so that they provide as much help to the patient representatives before the meeting as they can, so that the patient representative who usually for every 1 hour meeting spends about half an hour preparing for the meeting so that they can fully understand and participate. Very few patient representatives have, after the first meeting, complained that they didn't feel they were part of the committee.
That is excellent. That's an excellent feedback, Bernie. And just another quick follow-up question from Julie Swanson. Is your Speak Up materials available for use across Canada for free, with permission? Can they be adjusted for local requirements with names and phone numbers? Can you speak to that, or do you want to send us to someone?
I can tell you that if you look at the Jewish General Hospital's website, there's a section called Speak Up. And almost all of the information is there in both English and French. If you need any further information, I'm sure if you contact either Chris or Barb, they can give you my email address and I can work with you. We've given this program to hospitals and schools and institutions in the United States as well as Saudi Arabia. And I've always been very interested to find out, and I haven't, how Saudi Arabia managed to use information clearly labeled from the Jewish General Hospital in under their...
All right. We'll skip over that tiny irony and move on. Thank you so much for that, Bernie. So please do reach out to us if you do want contact for Bernie or find out a bit more about that information. Sandra, we did have a question for you. You mentioned the frictionless, consistent, convenient service that you were describing. Do you know of any resources available to help healthcare providers, whether they're pharmacists exclusively or even doctors, nurses, administrators, to be able to achieve that?
Yeah, so interestingly, this frictionless convenience is really a general consumer trend. So we're seeing it in everything. We're seeing it in the way that people shop, in the way that people search for information. So, I think that it's naturally going to start to find its way to healthcare, and it is. People are looking for it through health apps, through virtual care. I can certainly follow up with some resources that speak to how that frictionless experience is starting to work its way into healthcare. But I think the most important thing is really to understand that convenience is the number one thing that people are looking for today. People's time is the most important thing to them. So how can you work within their time and make, finding the answers and the resources they need most convenient and fast and accessible to them? So how do we work together to actually bring that to them and deliver that care in a quick, convenient, and accessible manner?
Perfect. Thank you, Sandra. If you do choose to share some tools that you've discovered with us, we'll definitely respond to any of the questions we get by email with those tools. So thank you very much for that, Sandra.
Yeah, I will send them.
Thank you. And Ward, we got a few comments enthusiastically supporting your choice of Greg's Wings film as a tool. So thank you again very much for mentioning that. Just curious, what were the best results you saw from rolling out teamwork training to undergraduates? Like, what did you find most effective among the suite of tools that you considered and then eventually ended up using?
Well, I think just the impact of the film to both make it immediately obvious why this is important, so to put relevance rather than just showing people some hypothetical possibilities. So I often draw on aviation examples like Stephen did, but I think being able to relate to something meaningful like a real patient, a young patient, somebody who should not have been dropped by our healthcare system like Greg was, really sort of brings it home. And I think being able to go back and forth between both exercises and Greg's story and a framework to reinforce what the key messages are has been extremely helpful. The students, I think, are appreciative of the commitment of the family, and I think it just heightens their willingness to participate in learning these quote unquote soft skills, which I don't consider them as soft, but most people would.
Not at all. And it is such an impactful film, too. Only 20, 25 minutes, and it is really an experience to watch that film. And you mentioned the other resources that you filmed afterwards to be able to support different techniques and everything. So bravo to you for the teamwork.
Yeah, thanks very much. People want to hear more,
Yep.
they can go to that Greg's Wings website, and they can become part of the Price family's community of practice.
Oh, that's an excellent suggestion. Thank you very much. Steve, curious, just from your perspective, what is the biggest barrier that you face when organizations are considering sharing patient safety incident information outside of their walls? What's the biggest barrier to them, or the biggest barriers that organizations in general face?
Great question. I would say two things. The first one would be a concern with privacy, patient information, which is a valid concern. But having said that, the information that is shared more broadly with the community is de-identified patient safety information with the intent for learning. So that information is stripped of all patient identifiers, any kind of identifying information, and it is shared for that learning purpose, which, contrary to what a lot of people think, there isn't any kind of legal restriction as long as that information is de-identified and shared for the sole purpose of learning and supporting others to prevent that type of harm. The second would be a little bit of concern with perception, which I would counter with, and I think we're seeing some definite changes in terms of patient safety culture on this, is a willingness to be transparent with that information. I think the expectation among patients and the health community in general is that you're transparent with that information so that you're demonstrating to the public, to the patients, that you are committed to not only helping others improve, but you're committed to improving yourself as well. So demonstrating that commitment to improvement by showing that transparency, I think helps push that forward. So those are the two key areas I think that when we work with organizations in Canada, but also internationally, those are two of the things we work to help them overcome in being a global leader in terms of sharing that information.
Perfect. Patient safety covers situations that involved patients with cognitive disorders, or what kind of preparation do you have to make for patient safety preparations for patients with cognitive disorders? Sandra, if you'd like to answer first.
Yeah, from my perspective, and in terms of the material that I chose to focus on, it's really about having that open dialogue. So it's really more preventative than it is reactive to situations. And I think it's important to have solutions on both ends, on the sort of preventative and ensuring that patients have that open dialogue and can ask questions so that we can try and prevent medication issues. And then, a number of the other speakers spoke to how do we look at what happens if there are incidents and how do we fix it to prevent it in the future. But from my perspective, with, patients with cognitive concerns, I think it becomes all the more important to think about that circle of care that I presented and to think about how do you best engage other healthcare providers? How do you best engage family and caregivers? And how do you ensure that there's open dialogue and flag the important areas and the important questions, I guess, that need to be asked and answered and monitored, and that it becomes a little bit more of a broader circle of care rather than dealing directly with the patient. The sort of circle of care becomes more and more important to engage in the ongoing dialogue and to ensure that that level of trust and open communication exists not only with the patient but with other members of their team.
Great. Thank you so much. Ward, do you have something to add to that?
Yeah, I might just say, Chris, if we go back to the concepts of team steps and just look at healthcare interactions through the lens of a team, clearly patients with cognitive challenges are going to need other family members to be part of their team if they're going to be effective. And we should never assume that people are members of a team. We should actually be explicit about that. So one of the first concepts of teamwork is to make sure that we know who's on the team, who's leading the team, and therefore that tells us who we need to communicate with and who we need to listen to. So I think it's just being upfront with identifying who that cognitively challenged patient includes on their team. It may be a family member, it may be a close personal friend, and then all the other constructs of teamwork sort of fill in the gaps there, including identifying the biggest threats to that patient's care, the patient's safety, and how to support that in order to keep patients safe.
Perfect. Thank you so much for that, Ward. I really appreciate that. I do have one follow-up question for you there, Ward. Is Team Steps or Team Scheme being used in undergrad nursing schools as well, that you know of?
Good question. So we've initiated discussions in our own faculty of nursing. I don't think it's, other than introducing them to it, it hasn't become the way of doing business yet, which is our goal. We've also tried to introduce the concept of teamwork throughout not just nursing, but throughout all of our allied health training programs through our Southern Alberta Institute of Technology. So it's slowly gaining a foothold, but we've got a ways to go. I think that's, again, the film helps because people are interested in the film, and so we're able to say, well, let's combine the film with formal training so that when we all end up in the same clinical scenario, everybody's talking the same language.
Yeah, I think that is an excellent idea. And we do have support from the chat box from patients who co-create curriculum for undergrads, et cetera. So I think there's a lot of support for that. I do have a question for Steve. Do you have any strategies to increase transparency in organization for sharing data, besides, of course, the Global Patient Safety Alert? But are there strategies you'd recommend to organizations to allow for people to be more free in sharing that information individually?
In terms of specific strategies, I would say no. I think it's a big culture thing. So like I mentioned with, concern with sharing the data, it's moving towards, slowly towards understanding that you can share the learnings, you can promote that. So I think it's a slow thing that you just need to be doing within your organization in terms of being willing to ask for that information, but also be willing to go out beyond your borders, whether that be within your province or territory, or even within your healthcare system. We can help facilitate that at CPSI. We can connect you with other organizations and leaders that have implemented some of those very specific strategies. So if you have something in mind that you're looking at, please feel free to reach out to us. We can help make that connection so that there's a little more connection between organizations that are quite simply trying to make care safer and trying to solve some of the very similar challenges. You don't need to go at it alone. You don't need to go at it among just your small group. There's a broader community out there that is willing to help, and we can help facilitate some of those discussions and connections.
Perfect. Thank you so much for that, Steve. Unfortunately, I do see we are at time. If you do have further questions, please respond to the email that's coming from our technical host, Barbara Laforte, and we will forward on your questions to get those answers back from our speakers. We do want to respectfully thank Lisa DeAngelis, Bernie Weinstein, Sandra Hanner, Dr. Ward Flemons, and Stephen Rutledge for sharing their time and expertise. Thanks, of course, to all of you for taking the time to attend on behalf of me, Christopher Thrall, and technical host Barb Laforte, and the rest of the team here at Canadian Patient Safety Institute. Thanks again to our sponsors, Gojo Industries and Health Pro. If you want to continue the conversation started in this discussion, please feel free to send us an email. We will post a recorded copy of this webinar on the CPSI website in the next week or so. Conquer Silence is here to stay. This week launches a multi-year effort to inform people across Canada about the silent epidemic of preventable patient harm and to equip everyone with ways to stay safe. Donate your voice to help us spread the word at the brand new site, conquersilence.ca. Join us for the next 2 webinars during Canadian Patient Safety Week, exploring peer-to-peer support programs available to healthcare providers after an adverse event, and a guide to the Protecting Canadians from Unsafe Drugs Act, also called mandatory reporting or Vanessa's Law. You can register for these, listen to our brand new podcast, and download tools to help you conquer silence at patientsafetyweek.ca. Please make sure to fill out our brief survey on your way out of the webinar. Have a wonderful day, everyone, and we look forward to seeing you again very soon.